Good morning, ladies and gentlemen. My name is Lukasz and I represent the Faculty of Management at the IBIMA University of Krakow. It is my pleasure to present the study entitled A Cost Infrastructure Assessment of UAV-based Automated External Defibrillator Transport in an Urban Polish Context. This research was conducted together with Professor Jerzy FELIKS from the Faculty of Management at the IBIMA University of Krakow. The study focuses on preliminary costs, infrastructure requirements, staffing needs, and organizational conditions that should be considered before UAV-based AAD delivery can be tested in a Polish city. The article processing charge was funded through the subvention funds of the Faculty of Management and the Excellence Initiative Research University program for the IBIMA University of Krakow. Let me begin by briefly outlining the structure of the presentation. First, I will briefly introduce the medical and logistical context of sudden cardiac arrest and explain why rapid access to an AAD is so important. I will then review previous research on UAV-based AAD delivery and indicate the research gap addressed by this study. Next, I will present the research objective, the assessment method, and the main assumptions adopted in the analysis. The following part will focus on the estimated cost of the two UAV pilot scenario and the wider scale deployment scenario. Finally, I will discuss the main conclusions, the limitations of the study, and the implications for possible future implementation. I will now move to the first section and introduce the medical and logistical context of sudden cardiac arrest. Sudden cardiac arrest is an extremely time-critical medical emergency, because the chance of survival depends strongly on how quickly effective intervention begins. In Poland, emergency medical services teams initiated cardiopulmonary resuscitation in 26,873 patients in 2018. At the same time, international research indicates that average survival rate to hospital discharge remains very low, at approximately 9.9%. The key issue is therefore time. If defibrillation is performed within the first 4 minutes after cardiac arrest, the patient's chance of survival may reach up to 50%. This clearly shows why reducing the time needed to deliver an AAD can have critical importance. This difference can be clearly observed in Polish data. An analysis of 120 cases showed that when an AAD was available and used by bystanders, defibrillation was initiated on average 3 minutes and 22 seconds after cardiac arrest. In the same cases, emergency medical services arrived after an average of 11 minutes and 58 seconds. Therefore, AAD use precede professional medical assistance by 8 minutes and 36 seconds. This comparison demonstrates the potential value of making an AAD available by bystanders as early as possible, particularly in locations where no device is immediately accessible. This leads to the question of how an AAD could be delivered quickly when no device is immediately available nearby. UAVs offer one possible solution because they can travel directly to the incident site and are less dependent on road networks and traffic conditions. In the proposed concept, the UAV carrying the AAD would be dispatched at the same time as the emergency medical service and remotely monitored by a certified operator. The AAD could then be lowered to the scene using a winch without the UAV having to land. Importantly, the UAV would not replace the ambulance service. Its role would be to provide earlier access to the AAD while the emergency team is still on the way. Previous international studies provide strong evidence that UAVs can shorten AAD delivery times. In Stockholm, they reach the scene before ambulances in 32% of urban incidents and 93% of rural incidents. In Toronto, the modeled reduction reached 6 minutes and 43 seconds in highly urbanized areas and over 10 minutes in the most rural regions. In Gothenburg, an 11-month implementation showed shorter response and delivery times in 67% of cases, with an average reduction of 3 minutes and 14 seconds. These findings demonstrate the potential operational value of UAV-based AAD delivery. Although previous studies have demonstrated the potential to reduce AAD delivery times, they have focused mainly on operational performance, cost structure, infrastructure requirements, staffing needs, and organizational conditions remain less extensively examined, particularly in the Polish urban context. To address this gap, the study develops and applies a preliminary ex-ante cost infrastructure assessment of UAV-based AAD transport. It aims to identify the baseline cost, infrastructure requirements, staffing needs, and selected regulatory conditions that should be considered before the concept progresses from a technological idea towards operational testing or possible broader implementation. Kraków was selected as an illustrative urban reference case for the assessment. The city has over 800,000 inhabitants and recorded 945 sudden cardiac arrest cases in 2019, including 211 in public places. The average EMS response time was 7 minutes and 38 seconds. For the purpose of the assessment, a reference technical configuration was defined. As presented in the table, the DJI Flycard 30 meets or exceeds the adopted requirements for AAD transport in terms of payload, flight performance, communication, and safety equipment. The platform was used as a reference for the cost infrastructure assessment and should not be interpreted as a final procurement recommendation. The ZOL AAD3 was selected as the reference defibrillator because of its portability and compatibility with the assumed payload conditions. A key organizational assumption concerns continuous operational readiness. In the initial 2 UAV scenario, one operator shift is assumed for the entire system rather than a separate operator for each UAV. Providing continuous coverage would require approximately 5 full-time operators. This is particularly important because personnel cost later becomes the dominant component of the pilot scenario. The table summarizes both the one-time investment costs and the recurring operating costs included in the 2-year pilot scenario. The total estimated cost is approximately €340,000. The most significant item is operator employment. As shown in the table, staffing accounts for approximately 79% of the total pilot cost, making it by far the dominant expenditure category. This result shows that the main financial burden does not come from purchasing the UAVs, AADs, or basic infrastructure, but from maintaining a sufficient number of qualified operators and ensuring continuous operational readiness throughout the pilot period. Moving from the 2-year pilot scenario to a larger scale deployment, the model assumes a fleet of 22 UAVs supported by 10 full-time operators and applies a 3-year cost horizon. Under these assumptions, the total estimated cost amounts to approximately €1.53 million, while the annual operating cost after this period is around €335,000. The main pattern, however, remains unchanged. Operator employment is still the largest cost component. This indicates that system expansion increases not only equipment expenditure, but also the organizational burden of maintaining continuous operational readiness. A few important limitations of this study should be noted. The assessment was not validated through real-world deployment and did not include GIS-based route optimization, EMS integration, or public acceptance analysis. Further research should therefore focus on pilot testing, deployment modeling, regulatory pathway assessment, and integration with emergency services. In conclusion, the study shows that the implementation potential of UAV-based AAD transport depends primarily on the organizational capacity required to sustain the system over time. The cost estimates indicate that continuous staffing and operational readiness have a greater impact on the overall resource structure than the acquisition of UAVs, AADs, and basic infrastructure. These findings shift the focus of preliminary planning from the equipment selection alone towards workforce organization, regulatory preparation, and integration with emergency response procedures. The proposed model provides a structured basis for early-stage planning by identifying the principal financial, infrastructural, staffing, and organizational requirements that should be considered before the pilot implementation. The references shown here include the main sources used directly in the presentation. A complete list of references is provided in the full paper. Thank you for your attention. I hope the presented assessment supports further research and contributes to the responsible management of resources required for UAV-based AAT delivery systems.